Hey, my name is Leah Cowart, and this is my final presentation for my pathophysiology class. Here's my name and date, and then this is my note card. So the disease I chose to talk about today is cardiac tamponade. This is when fluid builds up around the heart. It compresses it and doesn't allow the heart to fully and efficiently pump blood to the rest of the body. This fluid that accumulates in the pericardial sac, it can be blood, it can be pus, it can be some types of gas, just depending on the situation. Tamponade can be classified a few different ways. One way is going to be whether it's acute or chronic. Acute, of course, will be new, happening now, whereas chronic would be if it's been there for about 3 months or more. You can also classify your tamponade as circumferential, which is where the fluid is around the whole heart, or it can be more loculated, where it's just around one specific region of the heart. And then we also classify our tamponade based on the size of it. So a normal healthy heart is going to have about 10 to 50 milliliters of blood around it, just to kind of lubricate it, help the heart squeeze and fill appropriately. But when we get to about 100 milliliters of fluid, we're kind of leaning towards calling that a pericardial effusion. And then once you get to about 300 or more, that's when we kind of get to start worrying about the patient going into cardiac tamponade. Of course, it's very specific to each patient and their symptoms, but that's just a general idea about the milliliters. The etiology, so there's a few different causes that a patient could get cardiac tamponade. One is going to be a blunt force trauma to the chest, such as a car wreck, or maybe like a stab wound, something like that. Another scenario is going to be during open heart surgeries. So after surgery, they come up to the unit. I've recovered a good many heart surgeries in my 4 years as a nurse. And of course, the surgeon's in there cutting and stitching on the heart, so some bleeding is expected. They come up with chest tubes, so you watch the bleeding out of those, but sometimes those chest tubes can get clotted or the bleeding is just too much, and then tamponade can form then. The surgeons can either try to unclog the tube to drain the blood, or sometimes, in the worst case, they have to take them back down and open them up, evacuate the blood clots, and then hopefully the patient can recover. Some other scenarios are going to be any cardiac procedures where a catheter device is used. So thinking about like diagnostic heart caths or pacemaker implantations, things like that. Tamponade's always a risk. And then some patients with end-stage renal disease, cancer, and myocarditis, they're all at risk for tamponade also. Tamponade is a syndrome that's a part of the cardiovascular system. So now I'm going to talk about some of the clinical manifestations of tamponade. So your patient could come in complaining of symptoms of sharp chest pain, dizzy, lightheadedness, short of breath. And then as you do your assessment, you could see some hypotension, tachycardia. Listening to them with your stethoscope, you would hear muffled heart sounds. That's a big indicator. And then we also have something called Beck's triad. So if you have all three of these signs, it's a pretty good indicator that your patient's in tamponade. That's going to be hypotension, muffled heart sounds, and then jugular vein distension, or like the bulging neck veins. Some diagnostic tests that we do to see if a patient is in tamponade. One we do is an echocardiogram, or an ultrasound of the heart. Usually we find more like pleural effusions with these, but it's, if we find them as effusions, we're not pericardial effusions, not pleural effusions. If we find them on an echo, it's preventing them from getting to that point of tamponade. Of course, if your patient is crashing and you need to see what's going on now, you can't wait for an echo tech to get up there. We could get a chest x-ray, and that'll kind of show us a good picture of what's going on in there, and then also CTs. A differential diagnosis that I thought I would talk about. This is kind of more specific in heart surgeries when they first come up and you're recovering them, but it's hypovolemic shock because it looks very similar in the beginning to tamponade. You're going to see that hypotension, you're going to see that tachycardia, and then when we get a surgery like that, we always think in the back of our mind, cardiac tamponade. But you can do a few things to really differentiate it pretty quickly. If you give a fluid bolus and the patient gets better, then usually that means it's hypovolemic shock. They're not in tamponade. And then other signs like, of course, a hypovolemic patient isn't going to have the muffled heart sounds. They're not going to have the distended neck veins. If you have things like CVP where you can see that, that will be low in hypovolemic shock. So they both kind of look similar when you first get your patient up, but you can usually differentiate pretty quickly based on a few interventions and assessment findings, whether it's hypovolemic shock or tamponade. And then the last thing I'm going to talk about is some complications from cardiac tamponade. So the main thing, if tamponade isn't treated, your patient is going to go into cardiogenic shock. And this is when your cardiac output's low, your heart can't squeeze good, it's trying to overcome all that fluid compressing it. Some people will try to add some pressors for the meantime, which will raise your blood pressure. Some pressors that'll help your squeeze. But eventually, if you don't get that fluid off, the heart will stop beating and they will code. So hopefully the doctor can get in and treat the tamponade with a pericardiocentesis, which is when they go in with a needle through the pericardium, drain the fluid off. I've seen them leave like a pericardial drain in for a day or two. Sometimes they don't. And then if that's not possible, if it's that emergent, then they just have to open them up, take them to surgery, and get that fluid off quickly. But ultimately, if tamponade isn't treated, it does lead to death. And yeah, that's all I have to talk about tamponade. Thank you.